So I'm calling in from the traditional territories of the Lekwungen speaking peoples, specifically the Songhees and Esquimalt First Nation, and very grateful to be with you and that you've chosen to spend some time learning about PCN. I'm going to share my slide deck. I will try to make this the least boring possible. I will try to move relatively quickly, but not so quickly that we're, I'm getting the sense we really are doing 101 here. I'm going to start from the beginning and start from a sort of a big picture view, and then we'll come in and get very specific. So without further ado, I'm going to share my screen and, oh, host disabled participant screen sharing. Maybe Bev could help me by allowing me to share screen.
That's me, Joanna. I am up for the challenge.
I believe it, Leanne.
How about now?
I'm the host now. Right on. I got the power. You know that from Sheer? Anybody? No? Okay. Okay. So can you see my screen? Can you see Primary Care Networks 101?
Yes.
Yes. Okay. So this is what we just talked about. And thank you, Catherine, very much for your willingness to join me as well in your new role with the Rural and Remote Division. Okay, that slide. So here's what we're going to cover during our time together. Why change? We're going to review a bit about the primary care network and the patient medical home and how those two things interrelate. We're going to talk a little bit about governance, funding, PCN progress to date, current status, considerations, planning and implementation, PCN knowledge exchange, discussions and questions. I think we might pause at current status just so that we can have a bit of a dialogue. While I'm sharing screen, I can't see your questions, but Catherine and Leanne can moderate if it feels like we need to pause and just have a conversation. Okay, so first, a short story. I'm going to tell you the story. And sorry, I'm going to move your faces. It's always interesting in Zoom where the faces show up. Okay. So Joan and Jill are neighbors in a BC town. Joan moved in 8 years ago when her husband relocated for work. Jill has lived in the town since she was born. Joan, after she moved to this town, she tried for years to find a longitudinal provider. She wrote letters to doctors, she talked to friends, and eventually she just gave up. Jill, because she grew up in the town, she's had the same doctor since she was young. Joan, she's been accessing episodic care through walking clinics when her kids have earaches and sometimes from Babylon to get birth control renewed. On the other hand, Jill's family doctor ensures she's up to date on all the screenings and all of the preventative medicine that an individual would need. And because of this, a cancer diagnosis was caught early, treatment was provided, and she has an excellent life expectancy. Joan, on the other hand, she doesn't know she has cancer right now, and by the time symptoms start to show, it will be too late. Interestingly, Jill and Joan both have children that attend the same local primary school. When Joan moved into that town in BC, the school district catchment caught her and ensured that her children had access to the local primary school. As a society in British Columbia and in Canada, we have determined that children going to school is important enough to create a population level system, and we call it a school district. Primary healthcare, while needed by everyone, and certainly to greater or lesser degrees over the life course, has not had that same level of organization. If we were to run the school system the way we run primary care, we would suggest students be tasked with finding teachers with enough room to take them on. So if anything I say from this point on, whether you agree or disagree with how PCN's rolled out, the adequacy or the inadequacy of the templates, tools, and resources, I think as a society, we need to wrestle with the fact that we have a publicly funded system that isn't organized around the population. And who is the population? Well, it's our kids, our parents, our grandparents, our cousins, our friends, ourselves. And in all the friction we experience in the system, I really find it helpful to hold the problem and the future vision in my mind. And that was mentioned several times in the panel this morning. And I actually genuinely was inspired by the speakers this morning and the way that they're thinking about their communities. I feel like they very much have the PCN vision in their hearts and minds. So why change? So, I mean, I told you a little fictitious story there, but I think I'm doubtful any of this is going to be news to you, but I'm going to run through it briefly anyway. Our health system, it does need to change. It's not sustainable the way it is. So from a patient perspective, too many patients can't find a family doctor. It's approximately 1 in 6 in BC don't have access to a longitudinal provider. Family physicians are under a lot of stress. The threat of burnout is real. I'm going to share this just because I read it yesterday in the Canadian Medical Association journal. Physician burnout has many causes, including distress at not being able to provide highest quality care, lack of collegiality within and between medical specialties, concerns about fair pay, a feeling of misalignment with medical leadership, work quantity and pace, dealing with regulations, and using electronic health records. I personally felt overwhelmed just reading that paragraph, and that's not my lived experience every day. In terms of the system is difficult to navigate for patients and doctors. We need a more coordinated, integrated care system to manage chronic disease instead of episodic care. And we know that with people getting older, requiring more complex care, the pressure is just going to build. So what are we going to do? I feel like I'm not painting a very hopeful picture here. So let's dream the dream. What would we want the system to look like? And I think you could come up with your own list. Like, what would be some changes that would benefit providers, patients, and the system as a whole? So I'll give you just a short list. The goal of intervention for providers would be to reduce stress and workload, support the provision of comprehensive care, provide opportunities to learn new skills and approaches through collaborative experience, team-based care, support a sustainable practice model with the enhancement of a team. For patients, improve patient satisfaction, improve coordination, continuity, comprehensiveness of care, increase time with providers, and improve quality of care for patients with complex needs, and improve access to community resources and self-management education. And finally, for the health system, expanded primary care capacity, increased attachment of unattached patients, optimized scope of practice of team members based on patient need, potential for increased efficiency and cost effectiveness of primary care delivery, and the potential for improved sustainability of healthcare system, including the decreased burden on acute care facilities. So that, really that's let's just say, let's dream the dream. So in order for change to be effective and long lasting, I would say all partners need to be involved. You probably heard this quote before, but I think it's a really good one. And it's absolutely true of the primary care network. If you want to go fast, go alone. If you want to go far, then go together. So if you have a piece of paper in front of you right now, what I would love you to do is just try to sketch out what a pictorial representation of the school district system would look like. I think it's going to help when I show the next slide for you not to just feel totally overwhelmed. So if you have a piece of paper, just draw a couple of it can be, nobody's going to look at your drawing. So, you can just draw the schools, or you could draw, maybe the region, draw the way that you think that it would look. And I'll just give you literally 10 seconds to do that, because they can just be stick drawings, stick people, stick schools. I can't draw to save my life, but so mine's gonna be really fast. Although incidentally, I really do like Pictionary. Okay, here we go. There we go. Integrated system of care, patient medical homes and primary care networks with health authority services, community health services, specialized services, and acute care. So if you thought about this, I'm not sure what you draw on your piece of paper, and maybe you don't have a lot of interaction with the school system, but there's a lot of different types of schools in the school system. And there's access to different types of resources. And the only reason I got you to do that is that otherwise I find this slide completely overwhelming. Like, what is happening here? I'm going to just harken back to the summer of 2017 very briefly. There was a suite of policy papers that came out of the Ministry of Health outlining the expectations for an integrated system of care delivery in the community. Team-based care networks with patient medical homes as the foundation, connected to specialized community services, urgent primary care centers, and community health centers. I'm not going to say actually too much more about that because we're going to get into it later in detail, but that is the essence of this slide. It's trying to draw in your community, the hospitals are there, the private clinics are there, the specialized services the health authorities run are there, and they're all connected. They're not integrated. They are integrated. They're not fragmented, which I'm sure you've had experiences with yourself. I'm going to spend a moment talking about the patient medical home. And the reason there is a very cute picture here, as I just learned last week, that pictures of cute animals make us happier and actually more productive. And I just really like this photo, so that's why it's on the slide. It doesn't necessarily have anything to do with the patient medical home, other than it looks like it's in a home, and I like that. So you probably heard the term patient medical home, and the tension between the patient medical home and the primary care network, it's the best way to think about it is to think about it, to use your mental model of the school district now. And the patient medical home is a school, but it's a really great school. So when GPSC, there was a process called the visioning process. And out of that came the adoption of the patient medical home model, which was actually a product of the Canadian College of Family Physicians, which actually had been imported from the United States, and the work that their primary care physicians had done, all their primary care physician organizations had done to develop a model of what does great primary care look like. And so I'm going to zoom in on the wheel. And if you look around, look to the center of this wheel, and you'll see coordination, commitment, contact, continuity, and comprehensive. And if you've been in the primary care space for any period of time, there's somebody whose work has been foundational to primary care. Her name is Barbara Starfield, and she's the one who led the work around the C's, particularly coordination, continuity, comprehensiveness. And that it's one provider to one patient. And that's where you see the real benefits for a human being, them having care over their life course. So that's what's at the center of the wheel. And I should note, at the very center of the wheel is patient-centered or relationship-centered care between provider and patient. I'm going to draw your attention to the blue around the green. These are the enablers. How is it possible for one provider to be able to do all this? Well, it's because they've got a team supporting them. It's not just them doing it themselves. They have they're connected to other family practices. So family practices network supporting the practice, and patient medical home networks supporting communities. We're going to unpack a bit, is the primary care network. So that clinic is not just sitting on its own in the nether spaces of their community. They are connected to that umbrella primary care network. And there's structural enablers over here. We're not going to dive into that, but those are also very important. Okay, so patient medical home, essentially, it's an advanced primary care practice. It's operating at ideal level, and it's the core of the primary care network. Okay, another busy graphic, but just what I just said, you can see here, look, we've got the wheel in one of these homes and they're networked. The PCN, it is a network. I'm going to, maybe I'll just share this. So through the idea is that through primary care networks, nurses, allied health professionals, and other healthcare providers like social workers, dietitians, elders work with family physicians and or nurse practitioners so that everyone can work to their strengths, everyone can support and rely on each other, and patients get the best care. Okay, so I'm going to move on from that. I don't want to belabor that point. Okay, to be clear, who is the PCN? What are we talking about? And I like this image because it's got everyone contributing their plant or their piece of the garden to make it grow. You heard this morning, if you listened to the panel discussion, the heart of the governance is the division of family practice, working with the health authority and the local First Nations. So in many of your communities, you have something called the Collaborative Services Committee. That is traditionally and generally the health authority and the division sitting together at a table, working through primary care and often the specialized care needs in a community. And it is that Collaborative Services Committee, or the CSC, that applies through an expression of interest to form a PCN in their community. So we can get more nuanced about that and talk about the different people that come to that governance table, but at its essence, the people that form the primary care network in their community is the Division of Family Practice with the Health Authority and the local First Nation. And why? Because each of those groups already are providing primary care in their communities, very likely. Health authorities to a lesser degree, but sometimes to a greater degree, depending on where you live in the province. And absolutely the specialized services that they provide are a key component of what primary care providers need to support their patients. You know, so an example will be mental health and substance use support, specialized mental health and substance use supports, complex medical frail supports, home support, those types of things. Okay, so how would you describe a primary care network? How would you know when you happened upon one? Well, there are 8 attributes to the primary care network, 8 things that describe what happens in a primary care network. So the first one, and this was referenced this morning as well, I wouldn't say they're ordinal exactly, but the first 4 attributes are related to access. So in a primary care network, the people that live there can get attached. That means that they can get care. I can share with you the actual wording of each of these, the specific wording if you're interested, but access and attachment are this very interesting thing, right? They're 2 sides of the same coin, because you can attach everybody in a community, but you know, imagine one family provider attaching 5,000, 10,000 people. Those people are attached, but they're probably not going to get access. So patients in a primary care network, they have the ability to access and be attached to a primary care provider. The hours are extended. So there's access available more than just in the business day. It's on statutory holidays, it's on weekends, and in the evenings. Same day access is available in a primary care network. So if you need urgent care, you can get in. Advice and information is available both in person and virtually. Virtual care is a linked part of, or a descriptor of, the primary care network. The care is comprehensive. So it's over the life course. In a primary care network, you should be able to have a baby in your community, and you should also be able to receive end-of-life care. It is culturally safe. That's a significant piece of the work that's happening. Incredible work. I could go on about that for a while. Incredible work that's happening in the PCNs. Josh shared a little bit of what's happening in their community this morning, and yeah. Sorry, I could totally derail at this point. I won't, I'll stay focused. Coordinated care. Care is coordinated. So I'm sure you've experienced these giant cracks in the system as you've either been a patient or a care provider trying to move a patient through this system, and patients fall through cracks. So the notion here is that in the PCN, that thinking has been done at a community level within the health system, and the care is coordinated both between primary care provider to specialists to hospital care to labs, and back into the patient medical home. And finally, there's clear communication both inside and outside of the PCN. And that is a descriptor of what a PCN is like. Okay, the components. I actually put an umbrella here because I know I'm really hitting this point pretty hard, but I think the primary care network, I've heard it described as a process. Yes, it is a process. There is a process about forming a primary care network, and you have to define which CHSAs, which community health service areas your primary care network geography covers, the human beings that are cared for in that geography. But I really like this notion of an umbrella, that it is wrapping your arms around your community to provide excellent primary care. And the components listed there are patient medical homes, urgent and primary care centers, if there is one in your community, community health centers, nurse practitioner clinics, First Nations primary care centers, or First Nations primary care initiatives. And a couple of enablers to this work have been compensation models, new compensation models, and the Health Connect registry. Health Connect registry, the idea here is it's a big list, and it's hosted by 811 or HealthLink. I will just spend probably 30 seconds on this. One of the key things we've heard from patients in the system is that, how do I get attached? I need a family doctor, I need a nurse practitioner, and I don't know how to get attached. And I'm sure you've heard of this. I'm sure you experienced this if you're a provider, where people, they're literally bringing you a letter saying like, I won't be too much trouble. Would you please take me on? I was talking to actually a friend of mine this morning. He and his wife run a couple of clinics in town, and he thinks that they receive 80 calls a week in Victoria, patients trying to get attached. Their MOAs don't even call people back anymore. They leave messages. It's like they just can't even handle the volume. So the notion here is that there's one list, and that patients, it's not up to individual clinics to have to manage those types of calls. There's one list, and that people are pulled from it. The advantage of that, I'm pro Health Connect registry, and the reason for that is I think it quantifies the problem. We have rough data sets telling us how many unattached patients we have. We don't actually have a great list, and this system has already been launched in pilot communities and PCNs across the province. And I think it's better to, the patients don't have access now anyways, and so actually understanding the number of patients that don't have access with specificity, I think, is an advancement. Whoa, that slide. Catherine, did you do that? Yeah. So we got like, oh my gosh, it's we got a Star Wars thing happening. Okay, that was funny. Partnerships, you heard this morning. Partnerships and relationships. The primary care network will not survive, thrive. You won't be able to get it done without partnerships. And I don't think I need to belabor this point, but there are big organizational players like the health authorities. The Ministry of Health obviously is a key partner. Funding, they provide the templates. Doctors of BC with the GPSC, very much leaning in to support communities. But it's not all big players. It's local as was mentioned this morning, local community action is an incredible part of the strength of what makes PCNs work. Yeah, so some of those not all the partnerships are formalized like through legal agreements, but absolutely we rely on relationships that have been built over a long time to be strong and nimble. This is another slide that will feel overwhelming, and I'm not going to spend too much time here, but this is the governance of the whole province. So I'm going to start here at the top. So the General Practice Services Committee is a collaborative committee funded through the Physician Master Agreement. It is 6 doctors from the Doctors of BC that sit at a table with 6 representatives from the Ministry of Health. That is the General Practice Services Committee. The CSCs, so the local tables, where the division and the health authorities sit, they're here at this local level. In the middle of that are regional tables called interdivisional strategic councils or interdivisional councils or interdivisional collaborative services committees. Effectively, it's where the divisions and health authorities come together in a regional space. That's here. At the local level, we have, GPSC funds the divisions of family practice, and they contribute here. The ministry funds the health authorities and the First Nations Health Authority, and that's who's coming in here at the local level. And it is the CSCs that form the PCN steering committees. So that's the flow there. The PCN funding. I'm probably going to, I'm not sure what level of granularity you want to get into here, but we can just touch on these key points that are noted on the slide. The funding does come from the Ministry of Health. It is in their base budget. A portion of the funding goes to the divisions of family practice via the General Practice Services Committee, and a portion of the funding is provided to the health authorities. The funding is determined by need as outlined in the service plan. So there is a template that the ministry provides to a PCN when they're approved. And a key part of the work that happens right away when it's like, okay, great, you want to become a primary care network, we're going to do an analysis of the data with you. This is what the ministry does to figure out what your attachment gap is in your community. Once you have the attachment gap, the community looks at the health needs in their community and then tries to design a plan around those needs. The eligible expenses, part of the approval that comes back, it's part of the request and the approval, but there's contracts or funding for family doctors, for NPs, for nurses, and in some instances LPNs, allied health, elders, healers, and all of this funding, once it's approved, it funnels through the health authority. On the non-clinical side, funding is provided for a PCN manager, administrative support, governance, change management, which often includes evaluation. All of that funding flows through the Division of Family Practice. In some instances, like what Greg was mentioning this morning, capital is provided to upgrade a clinic, to create a larger clinic. So you can see how what government did here was, instead of creating a new entity, which was on the table at the time when these were first developed, it was like we could create a whole new entity that the health authority, a new legal entity that the health authority and the division form with their First Nations partners, or the funding could flow through the existing organizations. And that was the decision that was taken at the time. Creative PCN steering committee, where the steering committee actually holds all these funds in, like, together in a collaborative space, but their parent organizations, or the organizations they come from actually hold the funds. So the funds don't exist in a new space. They're held by the division and the health authority. The funding envelope is 3 to 4 years, depending on what the communities decide. That's specifically for the change management funding. The funding is ongoing for all the providers. So anybody in this line, family doctors, NPs, RNs, allied health, and the administrative funding is also ongoing. Okay, Catherine, over to you. Take a break from my voice.
Thanks, Joanna. So one of the pieces of work that I had over the last year working on Joanna's team was to sort of clarify the PCN EOI submission process. And so I recognize that we have some future PCNs on the call here, so we can sort of speak to some of the specifics during the Q&A session after this. But I thought I would just sort of go through what the process is to submit an EOI and what you can expect from that submission of the EOI through to submission of your service plan and approval and beginning implementation of PCN. So essentially, as Joanna said, the CSC is where the interest sort of begins and takes place. And so the CSC would put together an expression of interest using the EOI template and submit that through to GPSC. And so once a completed EOI has been submitted, that includes letters of support from the health authority, as well as the division board, that would then trigger the review process from the regional teams. So it doesn't go straight through to GPSC for approval. What happens is that the regional ministry, regional director, and your GPSC primary care transformation partner, along with First Nations Health Authority, as well as the Office of Indigenous Health, would review the EOI against a marking scheme and identify anything that may be red flags or may need additional clarification, and work with the community to ensure that all of those pieces have been met. So it's sort of an iterative process to go through that review. So once that's completed and everybody is comfortable that that community is ready to proceed, the regional director and the GPSC transformation partner would submit a recommendation for approval to the joint executive team at GPSC. And so once they review it and approve it, then the funds transfer agreement would be sent to community for the planning funds, so the 150 advanced planning funds. And that would trigger the beginning of service planning. And so once that happens, generally 4 to 6 weeks later, the regional ministry team will then send a package of planning documents to get started. So that will include the service planning template, as well as looking at the data. So the attachment data that's available, and sort of move into service planning with the community from that point forward. For wave 3+, I guess we're calling it now, Joanna, I'm not sure, future planning, you know, anything from this point forward, essentially. There is no deadline on the service plan. So wave 1 and 2 did have, I think it was 90 days, and then it was moved up to 180 days to submit a service plan. So there is no deadline at this point, just keeping in mind that the Ministry of Health does have a service plan and budgets in place. And so just obviously you don't want to spend 3 or 4 years service planning. So yeah, so once you're ready to submit that, you submit that to the ministry, and PCN implementation will begin after a series of sort of negotiations and meetings with the community from that point. I think that's about it, unless you wanted to add something to that, Joanna.
No, I think that's great, Catherine. And were you gonna, did you want to take this? Oh, did it move? Didn't move. Did you want to summarize the current status of PCNs?
Sure. So essentially now we've got 53 PCNs that are currently in implementation. Active service planning, we have 22 PCNs, and PCNs in the pre-planning and EOI development phase, we've got around 10. We don't know yet because this is not representing divisions, this is representing PCNs specifically. So that's sort of where we're at provincially with PCNs.
Great. Thanks, Catherine. Thank you.
And the next slide, I think, shows a listing of where everybody's at. That's right.
And in I'll leave it on the slide just for a moment. The Ministry of Health, in their service plan each year, the Ministry of Health tables a service plan with the budget. So the provincial budget that comes out in February, typically I think last year was April for the first time because of COVID. They table their goals for the year, and it's in a 3-year plan. And so their goal is to have 65, and thereby our goal, I should say, for the General Practice Services Committee, is to have 65 PCNs in implementation by the end of this fiscal year. And then I believe it's 85 by the following year. So yeah, those are the communities that are in development and in planning. Catherine and I chatted about this last week. I won't go through all of these, but there are a lot of different considerations within a PCN that are common. So you're going to end up in PCN, you're going to talk about governance. You're going to have to define what it means to be part of your PCN. It was interesting listening to Dr. Bonnie Bagden this morning talking about how they've defined that. And you know, those are conversations. There's a significant amount of change management that happens with this work. Attachment mechanisms, I mentioned that. Each community needs to figure out a way to get, if people are getting on a list, we got to figure out a way to get them off that list. And that's local work. Team-based care readiness, we have a team member, Erin Lutz, who supports PCNs and trying to figure out how to do team-based care mapping, and just there's a lot of work that goes into all of these various pieces. So I could go through all of these, but basically there are a lot of considerations, and there are likely templates and tools on absolutely anything you can think of or any problem that you run into. And if you run into a new problem, I'm sure that a new template and tool can be developed to support you. And the reason that I think that is that we are doing that actively. And this was when Catherine got a great opportunity in the Rural and Remote Division, and I am happy for her and excited for her, and also happy to still be working with her. But she was doing incredible work, and with the team, Nikita Soares, I'm not sure if you know her, but she is also a PCN liaison. And there's a lot of work that's directed to support PCNs at different stages of the life course. We have meetings specifically to support the PCN waves as a whole. So like the wave 1 PCNs come to I shouldn't call it PCNs, the divisions. The divisions come together every 6 weeks to talk and share their learnings and their struggles. We have a PCN leaders learning community. So the PCN managers, they come together. It's a whole new group of people, right? We haven't had PCN managers in the province before 2019, I guess. And so we're supporting them to have a community where they can learn and grow from each other. We have I'll just touch on a couple others. We have information sharing webinars. These are topical depending on what's going on. We had ones around pharmacists. There's pharmacists are a part of it. I touched on that, but there's a UBC pharmacy program that's part of PCNs. And so like we'll do a webinar on that as people need information. Okay, so there's, yeah, I don't think I'll touch too much on more on that. And there we are. That's the end of the presentation. Discussion and questions. I'm going to stop sharing my screen. Hopefully everyone's still awake.
Thanks, Joanna and Catherine. That was really great information. So there are some questions in the chat. So do we want to start with those, or do we want to just let the group start asking questions?
Totally up to you. I just see all the questions in the chat now. So I've got, why don't we start with the folks that have their hands up, and maybe if you had a question in the chat, you could just bring it into the main forum here. So Will, go ahead.
Yeah, thanks for that. That was really informative. So I guess my question is also, I don't know, it's also a little bit of a comment. Here in Pemberton, we haven't really gone through the process of PCN yet. We've been sort of holding back and seeing what other communities have done and what lessons can be learned from them prior to sort of engaging in it. We're hoping to get our EOI in relatively soon. But part of what has complicated the matter is, I guess, since the announcement of the First Nations primary care initiatives, that have rolled out. I'm aware of 2 of those initiatives that are taking place and now surrounding First Nations communities. So in that, I guess with the whole partnership piece, it seems like there's a bit of a like a, I don't know, it's just there isn't quite a match there when you talk about PCN being the overarching umbrella. Because it doesn't feel like we as the sort of healthcare providers in the community have much of input into the First Nations primary care initiatives, but yet putting in our EOI for PCN is supposed to sort of be the umbrella process for moving ahead. So there's just a little bit of disconnect there, and I'm just interested to know what some other communities have had in terms of their experiences with that and sort of the best ways to move ahead with this.
Great question, Will. And does anyone else have an FNPCI in their community right now that they could speak to? Amber does. Amber's got her hand up.
Hey, yeah, I hear what you're saying, Will. We're kind of in the same boat in Bella Coola, and our First Nation-led PCI is they're in their active planning, but it's true, we're a little bit not very involved, I would say, sort of in the dark as to what the plan is right now. And I have no doubt they're going to come up with a number of community needs that we will absolutely all agree on, that those are community needs and support 100%. But it is really hard to start developing your own PCN and identify what the needs are if you don't know what's happening in parallel. So in Bella Coola, what we've chosen to do is just sort of sit back and wait until that becomes a little bit more apparent, support whatever is happening through the FNPCI, and then try to fill in the service gaps that remain thereafter. But again, it's hard to know.
Sounds like the same approach as we have here.
Yeah, and who knows how long that's going to take, right? And I did also hear, was it by next year that everyone is expected to have a PCN happening in their community? Was that what the ministry had announced? Was it 2022? I don't know where that stands right now, but I had a small panic attack when I heard that, because I thought, wow, we're not going to have any idea what's going on by December. So yeah, maybe you can update us on that, Joanna.
Yeah, so their target is 85 by end of 2023, right? So I think so, or not end of 2023, March 31st of 2023. So the end of this fiscal is March 31st, 2022. And so then they'll click over into the next target, which is 85 by March 31st, 2023. So I think the question would be, does 85 saturate the province? And the lines of the PCNs are determined by the communities. So in the service planning process, actually, I think it's actually in the EOI application, you actually define which CHSAs your PCN will cover. And so the ministry hasn't actually, unless something's changed, which is it's possible, they're not defining the boundaries of the PCNs. They're leaving that to community. So that makes that the denominator actually a moving target. And I believe in the north, they have something called interprofessional teams, IPTs, and so their PCNs generally align to those interprofessional teams, which ends up there's more in the north, I think, that than there are in. Anyways, I'm getting off track. I think to answer your question, my guess would be that the ministry would like to have the whole province at least thinking through, if not at an implementation stage by March 2023. So Will, great question. And I don't have the answer other than to say, like, I would get involved. Like, is it come to the CSC table? Are you at your CSC table?
We are. I think at our next meeting, we're going to have some insight, some further insight into what those First Nations led PCIs are going to look like, because they're going to report back. But yeah, like, I guess it's just another sort of, it feels like it's another hurdle, but my greatest concern is that I don't feel like the healthcare providers that are currently in existence here are sort of engaged or been consulted about what those PCIs might look like. And I'll give a specific example in that we've known that here in the area that the social work piece has been a really big gap that needs to be filled, right? Like we've got lots of vulnerable patients that live in the local area that would really benefit from having a social work, an accessible social worker in the area. We've done a lot of work with this to try to get an early draw position done recently, right up to the point where, and it's rare that this happens, but the health authority were in agreement. We sat down with the health authority. The stakeholders had discussed this. We'd engaged with our First Nations partner to all come and say, look, this is beneficial to the community. We'd put it forward as an early draw EOI and was knocked back by the ministry, essentially in saying that we're not sure. We were essentially told, this may be asked for in either the First Nations led primary care initiative or through PCN, which was somewhat disheartening because the need is here. We've seen that the need currently exists, and by sort of knocking this back, it just feels like it puts us back a little bit. It's kind of like.
Well, I'm just gonna interject just because we've got a few other folks with their hands up. But what I'm going to do is maybe I can connect with you offline to reconnect with the transformation partner and reconnect you with the ministry. It sounds like you got a very specific example here of something that we need to work through the communication channels a bit better. Is that okay?
Yeah, that sounds good.
Yeah. I'm gonna attempt your name.
It's Maciej, guys. It's a very tricky name to pronounce, and don't feel bad about this. First of all, Johny Catherine, I love the energy. We all love the model. It's a great model. There's one thing I'm worried about. The primary rural care has been underfunded for decades. And basically, it was always people working in the communities that would do all the roles. Like Will just said, doctors doing social work badly, trying to cover for other services. I am worried about the financial part of this program because I don't see the millions of dollars that should be pumped in the system to work. I'm somehow a little worried that the model is good, but if it doesn't have enough power, it will just not function. And just like Will was saying, whenever we talk to health authority, we talk about the needs for our community, which are a little bit not exactly PCN related, like we have a problem with sustainability of our clinic. They always send us back, oh, you'll get the money for this in PCN, which is this pie in the sky that's supposed to bring all the good things to the community. But the information we get about PCN, the funds are very limited. We are struggling with recruitment of any frontline workers. As you know, the real estate market made it extremely expensive and difficult to move to a rural place, we're going to need much more money. I'm worried about the financial side, and I would welcome your comments on that.
Absolutely. And where do you live?
Oh, this is Gabriela Island, so we have a small
Gabriela.
community, and it's a small, rich community, and we are struggling. This is a community of white, rich, retired people who are eager to organize things. They build the clinic as a community clinic. There's a lot of spirit, and yet even we are struggling with just finding the resources around. So I cannot imagine, traumatized populations over the years, struggling with poverty, coming to have funds, organizational skills. I am worried about this part.
Yeah, no, you're raising excellent points, and I don't want to be Pollyannish about the challenge, and I don't think PCN, it's not a panacea in the sense of like it's not going to magically make doctors and nurses and allied health professionals appear. And I think your point about how much funding is required to close the gap to get to the dream that I talked about, where every patient has a provider, people are working in teams, there's a chicken in every pot, or whatever the analogy you want to use, that it's nirvana. I will say this because I heard it and I thought it was a great point. The government has never made a larger increase in funding or a larger investment in primary care than what they're doing right now through the primary care networks. This is a gamble for them. They are, I would say, making their best attempt with Treasury Board. So they get their money. I worked in Treasury Board for a period of time, bit of a soul destroying experience, but I learned a lot. So that's the financial arm of government, right? That's the cabinet committee, Treasury Board, and they have people called Treasury Board staff that they shepherd funding requests through the Treasury Board to come back to their ministry, in this case, the Ministry of Health. They actually had to go and ask for money. They had to say, we got an idea, we really want to fund primary care, would you give us this money? Treasury Board will basically never say, yes, let me give you all the money you need and want, and you can do whatever you want with it. That is just never going to happen. What they did say was, yes, we will give you this money and you can try. And so I think that's where we're at. We are at the place of they've been given money, and actually quite a bit of money. I think the initial investment, you have to go back. I'm going to not hazard a guess because I'll probably get it wrong. It is a significant amount of funds. What I think would be amazing would be for primary care, the primary care sector, to show great use of those funds, great gains for the population, so they can get more funds. So if you look at the team-based care ratios in the PMH, in the patient medical home, we're not hitting them with the PCN, with the amount of funds coming into the system. You're making a great point as well, like what about the people? So you can have funding for a nurse but not have a nurse, so that's a separate problem. I do think, though, developing a great primary care system is attractive when you have a system that looks like, hey, that's somewhere I want to work, or I want to stay working, I won't retire early, or whatever the situation might be. I think that's part of the potential that exists here. So I wouldn't let the lack of funds solving all the problems that we have stop anyone from getting going. Start moving, develop. Greg really kind of blew my mind, because I was involved in the early development of their PCN, and it was hard. That was like hard slogging, and what they've been able to do in that community is incredible. So great point, and I think it's a start. Tanya.
Hi, Joanna. Thanks. I always really appreciate your perspective on all things PCN. I'm the SOS PCN manager at this time. I was involved, though, in our original service plan as a nurse practitioner. And so now I am PCN manager involved in the rollout of our rural PCN service plan. So it feels like we're getting to do it all over again, but in a very different culture, actually, than when we did it the first time. So my question for you is that the first time we did this, we had those capital funds dollars, and they flowed, it seemed like a lot easier. It seems like there might be a lot more processes in place now. And we're seeing that the capital funds are flowing through the health authority. Is that a change across the board, or is that specific to our CHSAs and service plans and what we want to do with the funds?
That is a great question. I don't have the answer for, but I can find out. Because SOS was, and it was almost a pilot in a way. I recall the capital funds flowing, and I'm not surprised that they built it into the. I'm not surprised if that is a change where they built it into the capital envelopes that the health authorities have and their process for capital, but I don't know. So let me ask and get back to you.
Thanks, that would be great because they seem to be getting a little bit tied up in like the historic capital planning processes of the health authority and trying to figure out how that comes back to PCN steering committee.
Okay. Awesome, thanks, Tanya. Jane.
I'm from the Southern Gulf Islands, so Salt Spring Island and the Southern Gulf Islands surrounding, and we are in very early stages of thinking about the EOI, putting together the EOI. One of the challenges that we're having is that Salt Spring Island is has a number of physicians and has a very strong focus on working with patients who are living on Salt Spring Island. And the Southern Gulf Islands, the other Southern Gulf Islands, so Pender, Maine, they, if they need to refer or to connect patients to another place because of the ferry system, more logically go to Victoria. Victoria has just put in their PCN, like they're in year 1. So they've done all that PCN planning. And we're just in the early stages of starting and thinking about it. So that's why I was interested to see that like Burnaby and others have multiple CHSA models and communities. I think that's great. But how, as we think about how to address this in the Southern Gulf Islands, how important is it that a PCN model as a whole, so if you had 2 CHSAs, like one for Maine and Pender and those kind of surrounding islands and one for Salt Spring Island, how important is it that they have really similar experiences with their patients or that they're connected? Like, is it more logical for us to kind of try to push through and get the Southern Gulf Islands connected to Victoria? Or I don't know if you can speak to some of the challenges that happen for us, at least in an island system, when we might think about multiple CHSAs. Yeah, thank you.
What an interesting question. And I don't have an answer, but I'll just keep the conversation going with you here for a minute. So what is the population of those CHSAs?
Oh, you're testing me and I should know. Salt Spring Island, like 11,000. The other communities, I do not know. I'm sorry. I'm still too new.
No worries. That's and you're thinking right now, you were thinking of those 2 CHSAs would become 1 PCN?
Well, I think technically they might be seen as 1 full CHSA, but we really aren't. Like, we don't operate that way. So like Maine has its own clinic, Pender has its own clinic, but at least there's some connection between Maine and Pender. There really isn't between Maine, Pender and Salt Spring Island in terms of patient flow. Like, we don't care for Maine and Pender patients on Salt Spring. They go to Victoria. If they can't get the service at home, they would go to Victoria.
So you know what I would do if I were you, Jane, would be to look at I can send you the description of the primary care networks. And I think if you think about those populations and the flow and look at the primary care network attributes and see what you think makes the most sense. If you think it makes more sense to be part of the Victoria PCN, that would really be worth a conversation. I could see arguing it. I could argue it both ways. I know I probably need a little bit more information, but I think we can do, or I would be happy to sit down with you with Angela Thatchik on my team. She's the primary care transformation partner for that area. And we can just sort of do a little brainstorm about what would make the most sense.
Thank you so much.
Carrie.
Hi, I'm Carrie Marshall, a GP on the west coast of Vancouver Island. It's not so much a question, but just more a comment on the challenges of trying to simultaneously get the PCN started with the FNHA PCI at the same time, which has come first here. Brooke, our coordinator, is on the call. We have just really, from the beginning, been committed to try to go through those processes together. So what has happened on the coast, there's 8 First Nation communities, which is about 40% of our population. Through FNHA PCI work, they've all wanted to move to sessional or contract payments in their community, which the physician group is all on board with. We're about 3 physicians down right now. So the problem is the FNHA PCI funding is not going to be enough to cover all of the sessional payments in First Nations communities. So we're looking at trying to run the PCI as a complement to that, where the PCN, where the PCN funding is going to complement those gaps that aren't going to be met by the FNHA PCI. The other thing that we are working on is just the sense of urgency around getting more physicians on board. If we wait for all of these processes to go through and the funding, it's going to be at least another year. So we are working with FNHA and those partners really closely to hire physicians into our physician group, but are interviewed and vetted by the First Nations communities themselves as potential physicians that may be working in those communities, because I think those communities recognize the urgency. And the other thing is, if that hiring process through the FNHA PCI was going on independent, it would make it very challenging for us as a physician group, because all of our physicians on the coast also share call at the hospital. And so just trying to see that actually hiring independently, although, you know, the autonomy around healthcare service delivery in First Nations communities, we all support and are looking to expand. If that got hired outside of the input of our physician group, is going to create a lot of challenges and fragmented care between hospital and community care. So those are some of the things that we've done to, it's like trying to do this and understand which pieces come first, but basically just being committed with transparency from the very beginning and trying to work together has been the way that we're trying to go about doing this. We just had a physician interview with Chief and Counsel from a House It yesterday. So a physician we bring on board, he wants to start in January. PCI, PCN funding is not going to be at least another year. That First Nations community needs more physician services. And so they had facilitated through Brooke and divisions, interviewed that physician as somebody that's going to be working there once or twice a week. So it's sort of like saying, like, we have the people, or we want to bring on the board the people to fit your need, and just trying to coordinate those things. But it is a lot of work. And I think there's not a lot of precedent for it, you know, which makes it more challenging too. But that's where we are currently at.
Thanks so much for sharing that, Carrie. And I just want to affirm you, because that piece about you're committed with transparency, it goes back to that relationships piece. You are developing and actively engaged in relationships. And the reflections that I feel like we have been doing in British Columbia over the last year, and specifically on September 30th, it's kind of incredible where we're at in our society right now, to think that, you know, 60 years ago, this is not the conversation we would be having, where the health leaders are engaged with the local First Nations, trying to figure out how can we support the health needs of these communities. So while that sounds very difficult, the work that you're doing, I just want to say, like, keep going. Like, great job.
I mean, also, I was going to say that, well, I mean, the physician that this new recruit that we have before, we sort of committed to him. I said, okay, this is a new process. You're going to have to be interviewed and accepted by a House It leadership. And it just seemed wild that this was that this had never been done before for a physician that was going to be working in that community. I mean, and just in 2021, that this is the first time that that this happened was mind blowing. I think that it went really well. The other thing, we had our CSC yesterday, so there was, high level ministry and GPSC people were really helpful, because as a physician perspective, if I am looking at working in 2 to 3 different First Nations communities, which I am, there is a great barrier around thinking that my payment is I'm going to get paid through 2, 3, or 4 different payment systems, especially if the payment which is the goal, I think, is going to be moved to the band. So, that was something to bring up too, that when I'm in Coola in my clinic that I'm at now, I'm fee for service. When I'm in Hitatsu, I'm going to be getting paid by the Hitatsu band. When I'm in house it might be through First Nations PCI. And then when I'm in Tyastanis, it's through PCN. And that is not going to be very palatable to my colleagues. So, you know, partly it's like all the money is coming from the ministry and coming from the same place and going here. But as physicians, especially when you have a geographic, like many of us really, you have a geographic spread, that's going to be challenging to get paid through different programs. So I think that's something, a high level thing that needs to be thought about. We are, as rural physicians, we are geographically spread out.
Great point, Carrie. Thanks for sharing that. Dr. John Souls.
Yeah, I just had I mean, it was more in addressing a question about the Southern Gulf Islands and Salt Spring not having connections between them, but having connections to Victoria. So that really is very analogous to our situation in the Western Interior, where we have multiple communities like Clearwater, Lytton, Ashcroft, and Merritt that basically have little of any connection between each other, but have a connection to a central point. And we felt that was actually our rural interests and the commonalities between where we get our services was more important than the fact that we were part of a connected unit. And I just not sure if that's something that might suit the Southern Gulf Islands, but it's how our PCN is going to be modeled.
Thanks for that, John. Jane, did you want to, I believe it was Jane, right, that asked that question earlier?
Yeah, no, I was just writing a note to John to say thank you. I'm going to look into how it's modeled in those communities. And if I could follow up with you, John, after this call, that would be great.
Yeah, happy to.
Thank you so much.
Lovely. Nanette.
Hi guys, thanks. I was just hoping to draw on the group's collective wisdom and experience. And I kind of want to take it back a few steps and ask you, how did you get your physicians in your community to buy into this process and become engaged with this process? At the moment, the morale is low, the narrative is negative. And part of that for me as well is, how do you build succession planning into this? Because something that I've noticed is this burns out physician leaders fairly quickly. And yeah, like you need somebody, we actually have to have a team of leaders dealing with this and to try and tag and support each other, because it's exhausting trying to be positive if everything around you is negative. And so I'm sorry, I'm very sound very grim this morning, but just wondering how you guys do that.
I see Josh has put his hand up, and I'm guessing he's got some great insight here for us.
Well, it's not great insight, it's just insight. So I'm gonna use your teacher analogy, Joanna. And so Nanette, we don't expect teachers to teach in the classroom and run the school and apply for funding and recruit teachers to the school, right? And so the reality of the privilege that we have as rural physicians, or as physicians in general, is we do all of those things. And so my first pearl would be check yourself, right? You know, find a practice share. If you're going to step into that role, making sure you have support around you, right? My second thing is, you know, preach to the converted, right? So you're going to get people who want to be involved with this. And so spend more time with them initially and get them involved. And eventually they may be the ones who get a bit more resource, you know, at the start, because they're the one that can tell the stories that start to inspire people. We say as physicians, as clinic managers and stuff, that we like change, but we actually don't. And we have to acknowledge that from the very start. And specifically when we're burnt out, we really don't do it. And the third thing is then get the people hired early as possible. And I mean the managers and stuff, because much like the allied healthcare workers within the PCN, your PCN managers and your admin support are more important to the succession of the plan in the early phases than me as a physician want to buy in. And the more we acknowledge that and build our team, the better. And so that's our experience. For sure, there are some hard days and some difficult situations in that. And again, I know you personally, and I know how hard you work, and I know how challenging it has been. I believe, like Joanna, there is a future where we can do this collectively and together, but it's going to take some heavy lifting and some difficult spots. So that's wisdom or insight or banter, whichever you want to call it, Joanna.
find if you can gamify anything too, like the number of times you get a no on something, maybe you could have a bingo card. I don't know. I'm making a joke, but sometimes I have used that on my own team in ways that have been helpful. I'm going to not pronounce your name again. Mathieu? Mathieu?
Hi, Machi. Yes,
Machi.
that's right. You know, some question that overlaps what Kerry was saying and what Ninette was saying. I'm wondering about the power among stakeholders and specifically local communities and people living in local communities, being it, you know, First Nation communities or anybody living there. Because I cannot see a clear mechanism where people living in a place for which the service is being provided have actually say in planning and implementation and revision of this plan. And I think what would help with the burnout, what would help with the recruitment is strong support of the community leaders. And, you know, not every community has leaders or can organize themselves. And I just wonder what role the people living in a community will have in supporting the whole structure and deciding what's important for them because they're actually paying for it. And they're the ones who are on the receiving end of the clinic. You know, my experience when it comes to stakeholders discussing it, we were told many times that we should work with local health authority to negotiate, let's take a nursing contract. And it wasn't really a negotiation. We were given a contract and there was absolutely no room for negotiation anywhere. And I think this is what burns out physician leaders a lot is when they have this exciting initiative, they go to negotiate and it turns out actually it's supposed to be a negotiation. It really isn't. I think we would all have more power if we would have community partners sitting with us on those meetings who would have more power than anybody else actually saying what the community needs is this. And we need local authority to help us with organizing this. We need Ministry of Health for providing us with funding. And we need those guys sitting next to us to actually do the job. And I just wonder if there's any provision for that.
Well, I would open that up to the group if anybody has any reflections from their own communities on what Matthew is describing there. I think one of the advantages, so please put up your hand if you have any thoughts on his question. The one thought that came to my mind was it's probably not worth your energy to back up the bus. When wave one first got going, there were no funding parameters. There were no parameters at all. It was sort of like develop a plan. And I think one of the advantages of communities that haven't submitted a PCN plan yet is they have the benefit of all of that hard, heavy lifting. The wave twos as well had, you know, refined the model. So there are funding parameters now, and the process is much clearer. And it's actually, and there's not the tight timelines that wave one had. So wave one really, if you're ever in contact with the wave one community, it's worth hearing some of their stories because it was a very challenging experience. That said, I mean, I actually think that the ministry is being very flexible. They are willing, while they have funding parameters, they are willing to engage in local discussions about what the community needs are and do their best to modify or massage their own lines in order to support what the community need is. I would also say there's a limit to that. Like developing good relationships helps in any conversation, and then burning out relationships harms the conversation. So I would think you just want to be sensitive to that. So Catherine and Josh, I've given you others enough time to think what they want to say.
Yeah, I'll be really quick, but I feel like, so I agree with what Joanna was saying in terms of being able to sort of tailor some solutions. I feel like most of the communities that are left to go through this process are more rural. And so I think the ministry is recognizing that, and they're recognizing that there will need to be some tailored solutions for rural communities. I think one of the value propositions for rural is the fact that there is an opportunity for new governance. And I think that historically rural communities have been overlooked. And historically, not all rural and remote communities had CSCs or even had the attention of the health authority or anybody for that matter. It was physicians sort of trying to figure out what they needed, you know, begging the health authority for some sessionals to do some outreach or whatever it was, and hoping that would be sustainable. And I think that in this situation, there is an opportunity for, if nothing else, to solidify governance so that you have a voice at the table from now until the end of time, because who knows once the structure is in place across the province, it may not go anywhere for some time. And if the ministry decides to use this framework as a way of rolling out something else in the future, at least you have that in place in your community. So for me, that's sort of the way I've been looking at it for rural. I don't know exactly what it's going to look like in terms of your funding envelope in the end, but I feel like at least that governance will be there. There's an opportunity to have everybody at the table permanently.
Thanks, Catherine. Josh.
Joanna painted actually had quite a nice picture of wave one. Wave one's communities were told not to speak to one another, that there was a cone of silence around each of the individual places. And so now where we are is a dramatically different situation, and people are open and share. And so I would encourage, as rural communities, look towards other places, and places like the Pacific Northwest or the Comox Valley, who are wave one with rural environs, because they've had to sort out how do you not deal with, but how do you create reflection of voices and communities around you in the construct of the PCN. And then I think it's a mindset perspective, right? My job isn't to solve the problem. My job is to create the opportunities for engagement with the communities and our Indigenous communities, and then reflect the voices. And whatever that looks like, we're going to journey this place together. And so to this forum, I think it's a fantastic way to share ideas. And as Joanna used the old proverb, you know, if you want to go far, go together. And so come and speak with the people who are doing this, happy to share information, right? How it's gone. And this is a great opportunity to do that. So thanks.
Thanks, Josh. And I had fully blocked out that portion of the wave one's journey. Their journey was hard. Like there was a point at that process that I thought nobody's going to last. I mean, people were, it was a really tough slog for everyone, for the ministry, for the health authorities, for the divisions. It was tough. Don't let me paint a rosy picture. But I'm really impressed now, though, listening to the panel this morning about what's been created. Bev, you're about to cut me off. Go for it.
Nope, just letting you know that we've got 6 minutes left, and I did want to sort of add to that as well. So I think with the conversations that we've had with the Western Interior and looking at the rural communities, as John alluded to bring us all together, to put an EOI in together, I think the CSC has been very sort of strong in terms of setting the tone for what we need to sort of do at the local health planning tables. And so I think your question, Machi, around, how do you make sure that local communities have a role in planning and implementation? It's really looking at those local health planning tables and really building that relationship with your community, and having as many people there that you feel that you need to, in order to build that robustness for your community. It best, so who you sort of have at the table, and all of the tables are different in the Western Interior. There's not one table that's got the same memberships, because it's locally based. So I would really go back to that and really look to sort of have that strong communication at that CSC level and that local level as well. And we have 5 minutes left.
Awesome. Any final questions or anything that we didn't get to in the chat that you wanted to circle back to? Everyone's probably starting to feel hungry. I know I am.
I did have a couple of notes here. So just in terms of follow-up, and Leanne, I'm not too sure if certainly the First Nations PCI, I think really needs some I guess, education, and how that section with PCN sort of occurs. And so I think that is a pearl that I've gotten out of the conversation for today. And I think that everybody sort of mentioned that. It doesn't sound like there's been a whole lot of interaction, and the interactions that are happening are being done on the ground. And that to me is putting a lot of burden on the people on the ground, and you don't want to bring them out. So I think that would be a point that I think we should take away. Certainly recruitment and retention has come up. The rural funding, I think this next wave is going to be a lot rurally based, and really looking at opportunities to sort of impress upon the ministry that while we live in BC, rural is different, and they're not all cookie cutter, and there's a lot of knowledge to be gained from those, and payment structure, and that's sort of and that relationship-centered care. When you talked about the patient medical home, I really think that relationship-centered care is I think I really like that wording more than I like the patient medical home. So those were sort of the pearls. If anybody wants to add to to that I got out of the conversation today. And thanks very much for the presentation. And
Bev, can I add one thing? And that's just on the rural equity funding for PCN that the RCC provided for any of the wave 1, 2, and 3 communities. I think the number was 150,000, if I'm not mistaken. And it was for you to do exactly what you described, which was engage in your PCN region or your CSAs with in rural and Indigenous communities. And for us, that helped fund meeting times, locations, spaces, and physician time alongside directors and things to go and sit again in the longhouses, in the community centers, in the gymnasiums to do that. And that's where really the richness of the understanding of the PCN came from providers and NPs and mental health workers and chiefs and elders and teachers and all sorts of stuff. And so if you haven't accessed that funding that has previously been available, please reach out to the RCC, Kim Williams, etc.
Lovely. Thanks so much, Josh. And there's just a couple more takeaways I had. I'm going to check on the capital process and if that's changed. Jane's question about Salt Spring, that was another follow-up that we had, though I think Jane and John Souls are going to connect, and then that I think there'll probably be more insight in that conversation. So in addition to the FNPCI piece, and Leanne noted, and I think this is a great point, actually, there's a session that FNHA is doing this afternoon in this very forum. So that might be a great, that is a great opportunity. And there was one, Monica had her hand up, but it's down now. So maybe that was what she wanted to talk about.
I think we're good for time. I won't burden the group with more. All good. Thank you, though.
I'll just say my thanks to the Rural and Remote Division for putting this forum on and for inviting me to speak, and Catherine to speak, and for you sharing some of your life with me today. This has been a great discussion, and I'll put my email in the chat if anybody wants to follow up.